Nice to meet you.
I don't look at it. Oh, we are live. Wow. Okay, so it is March 29th and it's Friday. That's a little something to be thankful and happy about, I think. This is Senate Health and Welfare. This morning, we're celebrating Disability Awareness Day with some folks who've come in to talk with us, and thank you all for being here. This is terrific. So I've got a list. Susan, I'll turn it over to you and let you coordinate. We've got, 15, 20 minutes.
Great, thank you. Our first witness is Max.
So make sure you state your name for the record.
Yeah.
And we'd like to hear what you have to say.
All right.
Before we start, we're going to introduce ourselves just in case. So we'll start.
Good morning, I'm Senator Martine LaRoque-Ulick. I live in Burlington and I represent Chittenden Central. Nice to see you.
Nice to see you too.
Good morning, is it Max?
Yes.
Good morning, Max. I'm David.
Yeah.
I come from Proctor and I represent Rutland County.
Nice.
Good morning, Jenny Lyons, and represent Chittenden South.
Good morning, I'm Terry Williams. I represent Rutland County also, and I'm from Polkman.
Nice.
And Senator Ruth Hardy will be in. She's from Addison District, and Kiki is our assistant.
Oh, well, thank you.
Okay.
Thank you. So my name is Max Barrows. I live in Worcester, Vermont. I am autistic and I get developmental disability services. I work for Green Mountain Self Advocates. Green Mountain Self Advocates includes more than 600 members who are people with intellectual and developmental disabilities. We come from different religions, races, genders, and sexual orientations. When we advocate for equal access, when we advocate for equal access, rights, and opportunities, we are speaking up on behalf of our whole community. We want to make sure everyone in our community is heard and treated fairly. Hassan and I both live with our parents right now. Hassan is 29 and I am 38. We are comfortable living with our parents, but we know we can't stay with them forever. Lately, there has been a lot of talk about creating new places for people with disabilities to live in, like intentional communities. Today, I want to explain why Green Mountain Self Advocates is opposing intentional communities. So we think everyone should live together, not be segregated into separate places just for people with developmental disabilities. It's really good to make friends with people who don't have disabilities. When we have places only for those with disabilities, it can feel like there are too many rules. Sometimes people in charge use punishments that wouldn't be okay for anyone else. Like in my high school, there was a segregated program for students with disabilities. And I remember seeing a 21-year-old student with autism having to kneel in a corner just because of something she said. And that didn't seem fair. We want to live in, places where our neighbors can be our friends, no matter if, they have, disabilities or not. It's not right to separate people based on, disabilities, just like it wouldn't be right to do that for someone with, someone of a different race or sexual orientation. Would the state of Vermont fund intentional communities just for Blacks or just for lesbians? So why is it okay to do this for people with disabilities? Our opinions are backed up by reports like the 2023 research brief by Vermont Developmental Disabilities Council. The report describes how people with significant disabilities, pretty much get services they need while living in typical housing options integrated into their communities. The research found that, this quote, permanent supportive housing is a model used widely by other states. It can be configured in a variety of ways, clustered or scattered, with on-site staff or not. It aligns with the CMS settings rules and is associated with positive outcomes like community integration and choice. As demonstrated by some of the programs reviewed in this report, that with the right supports, a wide range of adults, including those with significant support needs, can live in supportive housing. When clustered in a single site, permanent supportive housing projects typically cap the number of units designated for people with disabilities at 25%, end quote. We know we don't want to live in intentional communities, only for people with disabilities. We want to live in typical neighborhoods with everybody else. Some say people with disabilities need to live in places that are just for us. But that is the same reason as Brandon Training School, why Brandon Training School got made. The old institutions kept us away from other people. They made it easier for us to get hurt and took away our freedom. People try and say that these new segregated places aren't like the old institutions, but they are. They might look like every other neighborhood, but only disabled people live there. We know that studies show we should live in the community. We also know one very important thing, that people with developmental disabilities don't want to live in segregated places. We know that we want to live in the community with everyone else. So on that note, thank you for listening to our concerns.
Thank you. And I know Act 186 has some recommendations about housing for folks with disabilities, and that would be that.
Yes.
And Senator Hardy has questions.
Thank you, Madam Chair. Excuse me. Thank you, and I'm sorry I missed the beginning of your testimony. I'm Senator Ruth Hardy from the Addison District. What is your name?
Max Sparrows.
Max Sparrows.
Yes.
Okay, Max, I'm wondering if I want to make sure I understand exactly what you're advocating for. So if there's a home that's supported housing for people with disabilities, and in that home there are only people with disabilities, but in the neighborhood there are more people without disabilities, is that okay? Or what specifically are you?
Here's how I'm gonna.
Okay.
If I were to live in like Montpelier, for instance,
Mhm.
or any city of country, I would rather live in a unit where I am living with people who do not have disabilities or within it. I don't want to live in just a compound
Mhm.
that is only for people with disabilities.
Okay.
Because it would just make me, I would feel left out.
Right.
I would feel like, I don't belong in the community. I want to live just around people with all kinds of backgrounds.
In your own apartment
Yes.
and with the supports that you need?
With the supports that I need and just within the community with people
Got it.
without disabilities.
Got it. Okay. Thank you very much.
Well,
Thank you. Thanks very much. So Susan, were you going to speak or how?
Next is Hassan Koh,
Okay, thank you.
and this is Hassan's first time testifying in person in legislative committee. So we're really excited that Hassan is here, and thank you so much for making it happen.
Thank you. So welcome. And you can introduce yourself to us and then read your testimony. That would be great.
Sure. My name is Hassan Koh, and I live in Winsky, and I live with my family. And I got a service from Champaign Community Service. I have a job. I have more than one staff. They support me in my everyday life, and that staff support me in my work. my staff need enough money to take care of their everyday life as well. I lose staff because they do not get paid enough money. We need more money to get them to raise. And we need to have more DSP at our agency. And since the COVID, we lost amazing people in my agency. And we keep co-worker having a hard time to be safe around. And I want them to stay with me. I don't want to lose them. Many of my friends feel the same way. It's very important to lose staff all the time. I need staff to work my job. I like my job because I work with different people with different disability people. And I need to go place to work with people with disability. I am a mentor. I guide them to what they need to do and give them a goal what they need. In our disability world, we have the same need as you. I help people get what they need. My job is important. I need a job code to do my job. Thank you for today.
Thank you for being here. And you are great at testifying.
Thank
You can do it again. Thank you.
Hi, Hassan. I live in Burlington, right next door to Winooski, so it's nice to meet you. And I'm really glad that you brought up the workforce shortage that we have that has been made worse from COVID. So I really appreciate you highlighting that for us.
Yeah,
Thank you.
because after like everything happening, it's very hard to be in normal again. So I want them to be like back to the what we used to be again.
Yes. Yeah. Where do you work?
I work for Remote Advocacy.
Oh, okay. Got it.
Yeah,
Well, you do a great job.
thank you.
Well, you probably helped get everyone here today.
Mhm.
Did you? Yeah, I thought so. Good job. It's good. You and
You're
I
a friend of
spoke.
Max's?
Yes,
Okay, Max, you mentioned this on, right?
Yes, I did. With pride.
So wait, so you two live far apart though?
yeah,
Yeah.
Yes.
You get together on a regular basis?
yes. Even though we are different part, we are still
You're so close.
working together.
Nice.
Max, where do you live?
I live in Worcester, Vermont.
In Worcester, oh, okay.
Yeah, north.
Yeah, cool.
Terrific, thank you. Susan, did you want to add? I know you had some testimony that you brought to us.
Yes, so I submitted a written statement. I would like to give the rest of our time to introduce someone who's not on your
Okay,
list, but I gave her card to Kiki. This is Anastasia Douglas. She's the chair of our council. So the Developmental Disabilities Council is majority of people. I am a staff person, but our council who I work for is made up of a majority of people who have disabilities or their family members.
okay.
And Anastasia Douglas from Barry is our chair. And since she's here today, I'd like to give her the opportunity to tell you what's on her mind.
Sure.
You see me all the
Why don't we do that,
time.
Anastasia, we don't have, just 5 minutes is fine. Yeah, that'd be
That
great.
should be perfect. I talk fast. So,
Not too bad.
yes. Good morning. My name is Anastasia Douglas. As Sue said, I'm a resident of Barry Town. I'm also a manager at Leonine Focus, the 50 state legislative tracking business at Leonine Public Affairs, who many of you are probably familiar with. And I'm the mother of 3 children. Miles is 10. He has autism, and this is him with his 2 Special Olympic medals from swimming, where Sue actually coached him. Rose is 7. She has ADHD, and this is her after a performance at the Barry Opera House that she did during February break. And then Eleanor is 2, and she spent some time in the NICU at birth and has some genetic complications and is in early intervention. My husband is the same employee. He actually does release planning at Chittenden Correctional Facility. So as Sue said, I'm the current chair of the Vermont Developmental Disabilities Council. I'm also the vice president of the Disability Rights Vermont Board. a member of the Berry Town Recreation Board, and one of the original organizers of the Berry Pride celebration. We're going into our 4th year on June 8th, and it's getting bigger and better every year. My community is really important to me, and I love having the opportunity to give back whenever I can. In 2017, when Miles turned 3, he graduated from early intervention into the school system, and the school system became responsible for his services. Up until that point, Miles received speech at daycare or at home. Once he reached 3, I had to leave work once a week, pick him up from daycare, drive him to school to have speech in a closet because they didn't have space at the Berry City School, bring him back to daycare and return to work. A year later, Miles participated in a trial extended day preschool at Berry Town. After seeing the differences in services provided between Berry City and Berry Town, we moved less than 2 miles at a considerable cost so that Miles could get the education he deserved. 2017 is repeating itself again in 2024. Eleanor turns 3 in September and will leave early intervention and receive services through the school. I talk about turning 3 as the cliff because you get pushed from this nurturing, home-based provider into everything being responsible for the parent. So it gives me a lot of anxiety because it impacts my job security. It impacts Eleanor's schedule. Anyone that knows toddlers knows that their schedules are important. And it puts me in the position where I have to decide whether her services, whether I can leave work, whether I have time to provide transportation. She's also a daycare in Waterbury, and so it's a lot different because we couldn't find a daycare closer. The other way that 2017 is repeating itself is the school budget crisis. Paraeducators in special education is one of the proposed cuts in our district. The budget failed in Berry City and Berry Town. I'm not going to allow my children to be put in a position where their services are cut. And I have the resources to relocate if I need to. I don't want to. The community is so important to me. But my kids are more important, and getting them the education they deserve, they need their services. At the council, we talked about what our happy ending looks like, so I wanted to share my happy ending. My happy ending would be providing children with early intervention services until they are in school full-time. And then also providing funding for schools so that parents like me don't enter each school budget season terrified that their children's services will be cut or underfunded. And so thank you for allowing me the time to testify. I also wanted to circle back because I'm really proud of being on the council. And so 2 of the platform items that we are asking this year for your support is including people with disabilities in existing housing programs and then supporting pay increases for service professionals.
Thank you. Thanks for all your work. You've got more than your hands full.
Yes, I do.
It's amazing what you're doing. Yeah.
I enjoy it.
Well,
Thank you.
The kids look adorable.
It's hard.
Amazing pictures.
Thank you. They are cutie pies.
So is she at the NICU with UVM?
Yeah, she was born not breathing, so she's intubated for a while. Thank
Well,
you.
thank you. And you've hit on a lot of the topics that we've talked about in here and will continue to talk about as we look at our budget responsibilities. Thank you very much.
Thank you.
Thank you all for being here.
Thank you for your time, and I'll let you read my statement online.
We have it. It was
Yes.
very clear and it's also extremely helpful. So
Yes.
thank you for that.
And the good news is, I know, Madam Chair, you've asked about a pipeline for housing.
Yes.
We got language for a pipeline passed last night. We'll see if it holds. So we'll
That's
be back,
very well done.
we'll be back on the other
Because we
side.
did talk about it the other day in appropriations. So it's nice to see this continuity. Yeah, it's great.
So thank you all.
Thank you. Terrific. Thank you all. You have a good day in the State House. We're glad you're here. Enjoy.
Have fun.
Bye now.
Take care.
Thank you.
It's interesting, I just read another article about ADHD and that how there are more and more young girls and women being diagnosed with ADHD. It's always been, you know, identified as a male issue.
That does not want to stay on the door.
Okay, so what I thought we would do, for a good chunk of time this morning is just become much more familiar with H72 and take a walk through with Michelle and look at questions that we have, the information that we gained from testimony and any suggestions we want to make for improvement. I know one of the suggestions that was brought to us was about some liability issues related to treatment and so on. So I don't know whether you put that in or whether we just look at it separately.
I didn't, so for the record,
Okay.
Child's Office of Legislative Counsel, so I started a draft and I
Yeah.
copied you on that, and
Right.
I'm going back and forth with Jessa a little bit on the language.
Okay.
Because what we have currently, with regard to immunity provisions related to overdose issues is really around protections from criminal liability.
Yeah,
And so they would like some civil protections in there and protections around licensing, so we're just kind of, we're just chatting,
It's
going back and
different.
forth with language.
totally different.
Right, so I thought, until we've kind of settled on something that I think everybody's in agreement with, no sense in you spending
Right,
your.
I know, and the
time on
board
that.
of medical practice or other boards might be involved in that as well.
Right,
Okay.
and so that's what I've started in on a draft, and I think I mentioned to you when I had done the initial walkthrough. That I'm just going to do some reorganization of the section because so this bill, as you know, has been kicking around for several years
Yeah.
and was really modeled after and then included in the Good Samaritan law that you have for reporting overdoses. And it was really just not very, originally not very much language and was just focused on the liability piece. And then it's kind of, blossomed as it's, gone through the process and added a lot more information and structure for the OPCs and whatever. And so what I'm doing in the next draft is just creating its own section that's gonna have all of that kind of information. And then I think it'll be a lot, it'll be easier to read and follow. And so those are the only two kind of changes that I've started on with regard to a new draft, but I know, you're reconsidering funding sources and things like that, but, do you want me just to go through the section so you can just be reminded what's in there?
I think it would be to go through at a fairly, a lower level pace, so we can actually look at the language and then ask questions or make suggestions.
Would you like me to put it on the screen or are you guys
Sure.
are gonna follow?
Yeah.
All right, you didn't sign down yet, I wasn't sure.
So did the temperature go down low enough last night so that
we're,
sugaring, that,
Well, didn't hear.
it did at home. And it's like,
It's gonna be hard, sir. Okay.
just. Kind of maybe one notch larger, if possible, sure.
like, this can be.
Oh, good.
How's that?
That's awesome.
Okay, great. All right, so we're just gonna go a little more slowly than we did initially about, and I think I didn't even really honestly talk that much because Representative Small did such a great job.
She did.
Doing an overview there. So, section 1, as I mentioned, so the way that it is currently, it's amending your, Good Samaritan law for reporting an overdose that provides for immunity from criminal prosecution for reporting an overdose. So this is we're working in, chapter 84, which is the regulated drug chapter in Title 18. So that's like where you have all the criminal laws, with regard to, possessing, dispensing and selling a regulated drug unlawfully. And so this will look different, but I'm keeping, all the the essence of everything together, but I am restructuring a little bit so I can get the new civil liability language in. So generally what you have is in subsection J, and again, this is, gonna change a lot, but, the purpose there is to provide for, immunity from criminal prosecution for possession. So it doesn't address dispensing or sale, just for possession, with regard to, so anybody who is associated, either whether, someone who's using the services, somebody who is running the center, working at the center, would be afforded immunity from a drug possession charge, related to their association with an OTC. I'll just note this because it is something that people are like, what does that mean? And I am keeping this language in some form in the next version, which is that when it talks about, and this language is also in your drug checking as well as your Good Samaritan law for reporting an overdose, is that the immunity provisions apply only to the use and derivative use of evidence gains as a proximate result of participation with an OPC. And that just means that, if somebody is in possession of drugs, they may be using an OPC, but if there is outside evidence that's not related to their use of an OPC, they can still be charged. So it doesn't provide blanket immunity so that somebody uses an OPC or is providing services and an OPC can't ever be charged with drug possession. This is that it's you can't, somebody walking into an OPC and, they're down the block and they're headed there and, they're someone who regularly visits the OPC, they can't, kind of nab you, on the outside when you're going into services or when you're leaving, things like that. But if they have outside evidence that's not related to the use or association with an OPC, they can still be charged. So it doesn't provide blanket immunity.
Is there any amount, or does it relate to other parts of statute that relate to the amount of drug that then, okay.
No,
Alright.
doesn't address, it just is straight up, if it's connected with an OPC, then
Because
there's no possession charge.
Distribution is different and sales are different.
Yes, and it doesn't protect against any kind of charges for dispensing and sale.
I'm just laughing because on the floor, remember I asked a question about dispensing?
Oh, right, you did, and
Michelle literally got me the green book with the definition of dispensing circled in the green book. It was so brilliant.
Well, it's a good question because
It is,
kind of think about it, and something that comes up a lot for people to say, does that mean if I, oftentimes it comes up in the context of cannabis, or if I pack someone a joint, is that dispensing? And it is.
Yeah.
So at top of page 2, subsection K is talking about what is an overdose prevention center. And then, so I'll go through since we're really looking at the detailed language. So the first is that it provides a space supervised by healthcare professionals or other trained staff for persons who use drugs to consume pre-obtained drugs. So there's no dispensing, no provision of drugs, and medication for substance use disorder. Subdivision 2 is that it provides harm reduction supplies, and y'all have seen all the testimony stuff, so you pretty much know what is in the subsection anyway. But answers questions on safer consumption practices, administers first aid if necessary, and monitors and treats potential overdoses. They provide referrals to addiction treatment, medical services, as well as social services. They educate participants on their risks of drug use, including contracting HIV, hepatitis, how to handle wound care, and safer sex education. They provide overdose prevention education and they distribute overdose reversal medications. They educate participants regarding proper disposal of needles and syringes. They provide reasonable security for the program site. Establish operating procedures for the program as well as eligibility criteria for program participants. And they train staff members to deliver services offered by the program. So that's just kind of the outline. And then you have in subsection L, you have the Department of Health establishing guidelines that's really kind of going to build out all of those types of details. So Department of Health in consultation with stakeholders and health departments in other states that have OPCs. They're to develop the guidelines not later than April 1st of next year. And the operating guidelines are to include the level of staff qualifications for medical safety and treatment and referral support. So you'll note that like in here's part of one of the things that was discussed in the House was, what level of training or certification or licensing, should people have there? And so this is just kind of providing the framework, and then it would be the Department of Health working with these folks to determine what's most appropriate to provide the services. So subsection M is on the application. So an entity can apply to the Department of Health to be an approved overdose prevention center. They can operate more than one program. And as you know, it can be at a fixed or a mobile site. And a safe syringe program can apply to operate in an OPC. I think Representative Small was talking about that, about the kind of co-locating those services. Subdivision 2, if an applicant complies with all of the statutes here, the rules and operating guidelines, the application is to be approved in 45 days. If it's denied, then the applicant is supposed to be given an explanation from DOH about why it was denied and kind of suggestions on how they might remedy their application to be able to be in compliance.
Question.
So I apologize for interrupting, but
Sure.
I just wanted to kind of touch on that particular language. So correct me if I'm wrong, but essentially the bill funds 2 pilot sites, but the language is such that it allows for other sites, and this is the process you're going through for those 2 sites plus additional. Would that be?
We haven't gotten to the pilots section yet, but
this
so
language-
Michelle, would this language then apply? Suppose the pilot programs are successful and the outcomes demonstrate, that they're important to the community.
Right.
Will this be the language that is used or the criteria and the information used going forward? So
Correct.
it is establishing a base for.
That's what I thought. I just want to make sure
Yeah.
that was.
Right.
Okay, thank you.
That's good.
So once an OPC is approved, the approval is for 2 years and then they can renew it.
Okay.
Page 4, subsection N, overdose prevention center can only operate within a municipality upon the affirmative vote of the legislative body of the municipality. So it would have to be like the select board would have to vote affirmatively to approve the OPC operating in their town. Subsection O is a reporting requirement for the OPC. And they have to do it on an annual basis. Every January, they have to report on, so, have a website and just make the information publicly available. So they're not reporting to the legislature or something like that. But if this is information that everybody can see, it would be the number of program participants, de-identified demographic information on those participants, the number of overdoses, and the number of overdoses that were reversed on site, the number of times EMS was contacted, the number of times law enforcement was contacted, and the number of participants directly and formally referred to other services.
I'm hesitant to ask you this question, but in line 12, law enforcement, is that plural or singular?
Cause it says law enforcement were contacted, but when you were reading it, you said law enforcement was contacted.
It's an interesting question.
Let's go for that one.
I think it can be either.
I think it can be either,
I just don't
but you know, I'll note it for my editors and ask them.
I promise I won't say anything on the
It's-
floor.
no,
I
it's-
completely created a monster on the floor.
No, it's totally fine, you know, there's so, I mean, that's the thing, I don't mind at all when people kind of ask those kinds of questions, because we want the product to be as good as possible, right? And I don't catch everything, our editors don't catch everything. You know, stuff comes off the floor after it passes, and then I get something back from the editors that's just passed and says, oh, here's a mistake, and I just think, gosh, we looked at that like 8 times,
Yeah.
all of us. And
know.
we still
Well,
have
that's
this
a good
back.
catch, maybe, I don't know, I think maybe it was, but
I
you decide.
just don't know what it is, like, generally, is that considered to be plural or singular? When you use the
They
phrase law
were-
enforcement as a
They
collective
were-
now, and you treat it as a singular.
Right.
So, and you're gonna restructure all of this and.
Oh, yeah.
Okay.
Yeah.
I don't wanna print out until we get to that.
Okay.
Yeah.
So section 2,
Wait, how is she restructuring the whole thing? I thought it was just the immunity thing that you were changing.
no, it's this whole section, I'm
Oh,
taking it out of the Good Samaritan law and making its own
It's all over the
overdose
place.
prevention section. And instead of like leading with the immunity provisions, I'm gonna lead with like, this is what an OPC is, this is what it has to do, and if you do all this, then you get these protections.
Got it,
'Cause
okay.
we just kind of backed into it with the immunity
This is a
section.
healthcare program.
Right, and I think that's what's clear in the language now, but because of how it's come about.
Yeah. Fair,
Yeah.
I appreciate that, thank you.
So section 2, is amending some language in existing statute around, needle exchange programs. And I'm trying to recall why, but I think what this is that, there were other different they wanted to not limit it to the organizations that are specified here on lines 20 and 21 with regard to who can operate a program. So I think it's just updating some language on the provision of those services. And then the same kind of idea in section 3, which is this, I think that I recall that in Human Services, we learned that the statewide harm reduction coalition that's mentioned on line 6 and 7 doesn't exist anymore, or doesn't meet anymore. And so that it was more appropriate to what's happening now is to have the Department of Health working with community stakeholders. And then the language on 10 and 11 is just, we don't need that anymore because that's long past and it doesn't matter. And then also just noting, and you have it in section 1 as well, that a needle exchange program can apply to be an LPC. So section 4 is the manufacturer fee. And we'll see line 19, where it's changing the fee. It's currently at 1.75% of the previous calendar year's prescription drug spending by DOH, and that is increased to 2.25%.
And Nolan did talk with us a little bit yesterday about the fiscal implications and note on this, and I'm going to invite Commissioner Levine and the Department of Health to come in and talk about this with regard to what the opioid advisory committee has done, and then where the funding is, and let's go through and understand it, but I don't know that we can make decisions, so we can get a little bit more information. Go ahead.
Just a question, in general about the syringe exchange program, there is none. And, I know one thing is, we're taking, like, people with diabetes, have to take injections, they were bringing them to the transfer station, didn't have any place to put them.
I mean, discard them,
Discarded it,
Yeah.
so maybe what we ended up doing was having them bring them in,
sharps.
no, they don't have sharps, they
Yeah, okay.
brought them in milk jugs.
Yeah.
So nobody got stuck, so is this gonna be incorporated into a larger program?
Well, this is what's allowed within the manufacturer's fee funding. doesn't have an expansion of what the programs are. Those are separate. So, but your question is a really good one, something we think about.
And vaguely remembering, did we do a film about just syringe disposal at pharmacies and expanding
Yes.
that?
Yes, we did. And that was for the folks with diabetes or
Right,
other injection
or
needs. Yeah.
Using prescribed medication, and so I thought we.
We did.
That
There could be one
Is that
We
what you
did.
did? Oh, you were, you was.
No, we did that. And,
Um,
and there are, and now there are new injection models that are less exposed. So, you know, you got a little plastic case, you do the injection and then the needle just absolutely disappears. But, so, we can follow up on that, but it's not exactly within what we're talking about here. But Senator Hardy's right. We did that.
But I don't remember.
Sort of the,
details.
sort of the take back. We'll try and sort that out.
But yeah, you're right, that's really inappropriate to have to, and not saying to have to bring it back to transfer station.
Jeff Hofford is a good guy.
So just on the section that increases the percentage for the manufacturer fee, it's also adding as one of the approved uses is the grants for overdose prevention centers. And then the next section, section 5, is the counterpart to that, which is the fund. And again, it's just amending the fund to add OPCs as a approved use for monies within the fund.
Yeah, so theoretically, the theory somewhere out there that we've heard is that once the OPCs go into place, then over time and recovery centers go into place, over time, we gradually see less and less of a need. You know, given the influx of drugs, I don't get that perspective.
So section 6 is the appropriation from the fund of $2 million. And for the 2 sites.
For 2 years? Or for 1 year?
It's just for FY25.
Yeah.
So section 7 is a study. On or before December 1st of this year, Department of Health is directed to contract with either a researcher or an independent consulting entity that has expertise in rural addiction, in the field of rural addiction, or overdose prevention centers, to study the impact of the 2 pilots. It's to evaluate the current impacts of the overdose crisis in Vermont, as well as any changes for a period of 4 years. And so some of the things are to be looking at, seeing subdivision 1 starting on line 4, the current state of the overdose crisis and deaths across the state, the impact of overdose prevention center pilot programs on those deaths across Vermont, with focus on communities where the pilots are established. The current crime rates in those communities where the OPCs are established, and the impact, if any, of OPCs on crime rates in those communities. Subdivision 3 is the current rates of litter syringe in those communities where the OPCs are located, and then looking at that over the period of 4 years and the impacts on that from the OPCs. Subdivision 4, the current rate of the number of emergency medical calls related to overdoses, with a focus on those communities where the pilots are established. Page 10, subdivision 5, current rate of syringe service program, participant uptake of treatment and recovery services, and the impact of the OPCs on the rates of participant uptake of treatment and recovery services. And then finally, the impact of overdose prevention center pilot programs on the number of emergency response calls related to overdoses. So subsection B is there to do, the Department of Health, working with whoever it is they hire to do the study, is to provide the General Assembly with annual, reports on or before, January 15th each year, and then they do a final report in 2029. Which will get status reports every year.
Okay.
And then section 8 is the appropriation from the opioid abatement special fund to Department of Health for the study, and it's $300,000.
So in addition to the 2 million from the manufacturer's fee, we have 500,000 for the analysis by the DOH.
300.
So it helps with context. Do you happen to know what is currently in the budget relative to this? Because we'll be looking at that. I in particular will be looking at it. And I think we've expressed concerns about the manufacturers thinking about the opioid abatement fund. So we'll be taking, as I said,
Right.
taking testimony, but I didn't know if you had any.
I do not, I have to
That's okay.
say, I'm,
Good job.
I just rely on Nolan's
Yes,
excellence
I know.
for
He's
dogging
really
up all of that kind of stuff, and I assume he'll just let me know
Yeah.
where the money is, where I need to put it.
So we'll sort that out, but it is an issue that will be of concern to us. So I'm gonna ask committee if you have suggestions, other than the money itself, and where it comes from, suggestions on the language or the criteria or any of the policies that are embedded here. So overall, it's what? 2-year pilot program for 2 different sites.
Right, the funding is, so the enabling legislation just sets up the structure, so there's no limitation really on that. And so where it's limited is how you're gonna,
With the
how you're
funding.
gonna do it through funding.
Okay. And so if someone came in from Montpelier and all the funding had been expended in 2 other parts of the state, but they had met all the criteria and they had their own funding. But
As long as they went through the process with Department of Health and they met all the criteria, then
then they could be approved. Okay, but then the Department of Health would have to keep track they'd have to keep track of all the data. Senator Go again.
I have a question, and I'm not sure who will be able to answer it, but I never thought I'd say I'm excited about OPCs, but I really am excited about the prospect of what this will bring to our communities in hopeful and positive ways. My question is around, this came up in testimony last week around the location of the OPC within a municipality. Is that gonna fall within the jurisdiction of the city council, the board of aldermen or whatever? Is that who will, okay, so
The
the site
legislative body
location-
would be the ones deciding, so they probably could say, this is where we want.
But I thought, so is it a local decision or is it a legislative decision?
Local.
Okay.
yeah, there's nothing in here that says, it must be. Or it can't be in these particular locations or whatever, it's just gonna fall to the municipality in terms of what's the most appropriate location.
Right.
And
Thank you.
and they have to approve it before it would be allowed to operate.
So is it anticipated that the municipal governments are involved not only in saying yes or no to the overall concept, but also the location? Do they really have that much control on
If
location?
you're
I mean, I think it's gonna depend on their zoning, on whatever their municipal structure is in terms of that sort of thing.
I envision actually going to the voters too, because somebody will get a petition to try to stop it.
It could,
So it end up as an article on the ballot. So is that provision allowed for within this?
This is, I mean, somebody could do a petition and then lobby their local legislative body, but this language does not require a vote
Right.
of the citizenry to be able to approve it, like the way that, for cannabis retail shops, there's a provision in law that requires an affirmative vote that's
Right.
put out, like a town meeting or in fall. But this is for the local select board or city council to do that, and so it'd be up for people to just be talking to their local legislative body about it. And if it was proposed for us, for a location that people felt was inappropriate, then they would, you know, be talking to their local leaders about that, and then the local leaders would decide, say, well, we'll approve it, but it can't, we don't want it here, we want it over here, that sort of thing. So it would be, you know, up to the local legislative body to determine whether it's. Go ahead.
So one more thing, back towards the beginning of the bill, it talked about, available, the OPC would coordinate for social services. And I'm trying to think about, trying to envision what's gonna be inside, the, you know, they're gonna be some of the opioid testing machines that we purchased with the settlement money there, so they're actually gonna test, they're gonna test the drugs that the people bring in and they wanna use, make sure it's not.
Well, could, I mean, that will potentially be up to the Department of Health as they develop guidelines. You know, whether they, the testing equipment needs to be there, they very well could say, yeah, we want the testing equipment there. Seems like a good idea, yeah.
Yeah, because if you don't, you may end up with more overdose.
I mean, we can start defining down into the very specific details, but I think the folks at DOH will have some oversight and some information, as will all the other interested parties, stakeholders. So, yeah,
So
Process.
there would be somebody there, maybe like an administrative section, or if somebody needed social services, wanted to, you know, be a treatment.
so, yes, that's a really good point. So there will be people there, like a Grace Kellers or others, who recognize that someone who's coming in with an addiction, it might come in and there's that little tiny space where they want help. And if they come in and they have support services and say, yes, we can get you to recovery. So they can help them right then. So that's really an important part of the whole process. Had a question.
I was just, can I add something to? It might be helpful to visit one if you have the time, you know, that Senator Dehuski was trying to do a field trip. Just to sort of see what the services are that they provide and how they do it. Or I think there is.
We were gonna invite the person who runs the New York City
Right.
Program to testify, and I think we will do that.
I think they have a video tour. Yeah, I seem to remember that we saw that in the overdose prevention, the opioid settlement committee. That might be helpful for you to sort of visualize what it looks like and how it works, how it's set up.
I mean, it's like, you know, go look at some of these nursing homes and say, I wouldn't want my mother in this place. You know, it's like, you know, want to make sure it's clean and people are professional and they know what they're.
They're really clean.
Yeah,
they're
it's like walking into a clinic. You saw the pictures yesterday and the pictures last week. It's not under the bridge. I mean, we all have that perception. Not many people have that perception of litter around and people, but this is meant to be a place that is clean and helps people clean themselves.
So who provides oversight to make sure that that facility stays that way?
The practitioners who are there.
No, I'm talking about the government.
The
And
government.
we make a law, who's responsible?
Department of Health is establishing the guidelines. They probably will go out and look at the place. And then they'll say, yes, this is good, and keep an eye on it. There have to be reports back of everything. Now, these are people who are professional clinicians, whether they're counselors or whether they're nurses or whether they're docs. They're not gonna have something that isn't professional.
About like my colleague, across the table there saying, I'm excited about it, but I'm open-minded about it.
Well, glad. It's important to be open-minded about this. Takes time.
Some of us live very close to Montreal as opposed to New York, and I'm wondering if a visit to see an OPC in Montreal is it worth doing? Like, are they similar enough, or is the
Let's see
Canadian
what we
model-
can get from the New York City folks who already have them on our list, and we'll see if we can get the video or some testimony that would help.
Oh, fun. It would be welcome.
Overnight,
What?
overnight.
I'm just wondering,
Overnighter.
I'm wondering if their model is similar to what we're doing, or
I
if
don't
it's
know.
different. We should.
Based on the
I've been to
photo- the
Vancouver.
pictures I've seen and the information I've seen, they are very similar. I mean, in Montreal, it's in French.
Maybe.
Uh-oh. Vancouver was nice. Anyway, so yeah, it's a good place. So Michelle, what are we missing here? Are we answering these questions? You got.
I think you guys, you've got your head around it. I mean, in some ways, I mean, I realize it's not a simple bill from a political standpoint, but there's not a lot here. It creates the structure. This is what an OPC is. This is, Department of Health is gonna be developing the guidelines. There are immunity protections for folks as long as they are acting in good faith and in compliance with those guidelines. And then the funding pieces.
So my suggestion is this to all of us, and we'll go back through the bill, we'll try to get the New York folks and the Commissioner of Health, and we need to deal with the funding piece. Look at we'll try to bring some information from Nolan on the budget piece, and then we'll look at your chapter structure.
And I'll keep chatting with Jessa on how.
Good, yeah, that piece.
On the civil liability piece.
And then, so the next time we look at it, let's look at it with an eye to having some fine tuning, trying to get to the funding as much as possible, and then we'll be able to finish the bill. And I'm thinking the week after next, we'll be able to say, we'll be able to make a motion on the bill. That's the goal, okay? Okay.
Thanks, sorry, yeah, I think you missed my hand. But,
Oh, my.
I just wanted to say thank you to whoever was responsible for crafting this bill, because to your point, it is simple, not too simple, but it's simple and it's digestible, and I really appreciate. I appreciate
the
it.
complex.
It's not overly complex. That's good. So thank you.
Let's not call it something. Yes. Centerpiece.
Yeah, simple's not the right word. Sorry, should never use that word. It's elegant.
So if we're talking about future testimony for the bill. Wondering if we're rescheduling the teachers. They were on the.
I'll ask them. I'm not, the interesting thing is recovery centers are a distance away from this, so
They were,
frequently recovery centers do not want to have any drugs present. So they probably would say, yeah, this is a good thing, but don't do it on our property. That's the way that works. So I can ask Greg what his interest is.
so it was, yesterday, there was a good testimony about at least two different approaches to this same problem. One being injection sites, the second being abstinence. I'd like to hear from some abstinence advocates. It's a completely different concept, but it's addressing the same problem. And I don't think we should focus 100% on.
So we did hear from Lila Bennett from the Northeast Kingdom, who spoke very eloquently about their program and that they would not allow for the use of a harm reduction process like this one. That one, and I don't know that certainly if you haven't, there's a qualified expert on abstinence, we can do that.
Well, I think
Sometimes it comes down to a rejection of immunity, allowing people to use drugs in a public environment. Go ahead.
So that's
Then
one.
Senator Hardy must speak.
The second is, I think we need to hear from someone who, if the injection site concept moves forward, which it appears that it's going to. What is the notion of how many of these centers are necessary for the state? Not 2 pilots, but a whole state, what's necessary. So we're not just looking at our feet, we're looking over the horizon at the total solution, not a partial solution.
So here's my suggestion on that. We could ask for a report back as the pilot goes forward about geographic distribution based on population centers. We could ask for that. We can also see that's the question you're asking is a question after the pilot. I mean, it really, so if we can, that's kind of the planning process as we've had for hubs, for example. We got hubs in very few places in the state. Now we're seeing success, so they're starting to have greater distribution. Similarly with this one, if we see enough lives saved and enough people moving into recovery, then we'll say, well, how can we expand them? It's not a question that can be answered in this bill. I mean, we really can't say where should they be.
I'm not asking for it to be answered, but I'm asking for it to be addressed in your testimony. I don't think it's that complicated. I think we know the numbers. I think the numbers with certain assumptions, and that's how we can approach any problem is make certain assumptions. I think that we,
Who would you like to testify?
I don't know who the expert is, but I
Department
think,
of Health.
again, I'm not the expert on this topic. I just know that we're not just talking, we are currently just talking about 2 ballots, I get that. But we know the problem. We heard lots of testimony on the numbers of, from former addicts who told us the numbers of times that they, use drugs in a day. We have an approximate number from different centers and how many customers come through. I mean, we can figure out notional numbers. And I just want to get my head around, if I can, what the total solution is, not just the pilot solution. I think that would be worth 15 minutes of conversation.
So
because it's
I'll ask the Commissioner of Health to speak to that when he comes in, or his substance use disorder folks to speak to that. But ordinarily, what you do with a pilot is to use it as a way for determining next steps. And you're asking for those next steps.
No, I'm asking for, to create an assumption on the total population and the next step solution.
Okay, so you're asking for the population centers of the state that have the highest drug utilization. So should we put these OPCs in each of those places? That's what I'm hearing. I'm hearing you say Burlington, Brattleboro, Rutland, Montpelier, maybe even St. Johnsbury. I'm hearing you say these are our population centers where we have the highest drug utilization and overdoses. So, and then beyond that, I'm not sure. If that's, I'm just sure. So what I am sure about is, let's see what our legislative bodies have to say, and let's see how see how these things work as a first step. Senator Hardy is chomping at.
Yeah, thank you, Madam Chair. It's, okay, I have a few things to say to respond. First of all, in terms of that whole notion of abstinence as an alternative to this, I think it would be helpful to hear actually from a medical professional who can explain to you what happens when somebody has opioid use disorder. It is a physical illness, and abstinence is not a cure. It's not even possible for somebody who is sick with opioid use disorder. And so to say that that is an alternative to an opioid prevention site, it's not. So, there may be at some time down the road in somebody's recovery that abstinence is appropriate. But at the time when somebody needs to use an overdose prevention site, it is absolutely not possible. It is just not possible for that. Wait, I have a little bit more to say. In terms of the, who to hear from, in, sort of like, what is the sort of big, end game, of how many of these we need? I actually don't think the commissioner is an appropriate person to hear from. I think he doesn't have the expertise or the understanding of it to answer that question, but I do think that, Representative Small did answer this question yesterday. It's that, and I think as the chair has alluded to, is that usually when there's a pilot program, it's to see if this, how can this work and how does it fit into the greater sort of landscape of treatment, recovery, and prevention services that we have throughout the state. This is not, and nobody, even the biggest advocates, nobody's saying that this is the be all end all solution. What they are saying is that this is an important, piece of our puzzle to helping to solve the opioid crisis. And so I don't think that there's sort of a plan to have an overdose prevention site in every single community around the state. I think there's an idea that we need to see how does it work in our biggest city, which is pretty much chomping at the bit to do this. And then how could it work in our smaller communities with a mobile site or temporary sites? And then we would know more about whether it's feasible or practical to expand it to other sites. We also have to wait to see how the money that we appropriated last year is literally just still not even out. We need to see how everything else is working too. So this is just a start. I don't think anybody can answer the question of how many of these eventually do we need.
Can I say something real quick? First of all, I understand what you're saying, but don't tell me that people can't just cold turkey quit, because I saw my brother do. So, but he was not hooked on it because of his choice. He was hooked on it because a doctor kept giving it to him because he was in excruciating pain. Second of all, it's a regional thing and it has politics that get involved with it. The people in my district don't want anything to do with it.
Exactly.
But the people that are addicted in my district, they go home or to their apartment and you see them in the obituary the next day. So it's sad. And I'm gonna tell you, I've been walking around the streets of this town and it's sad. The people that are addicted that are on the street and using, and they don't have, so I get both sides of it. But don't tell me that people can't. There's different extenuating circumstances. We want to hear the whole McGill before we take a vote.
I'm with you, and so what we're gonna do, and this is a really good discussion, I have to tell you, and I wanna continue the discussion, I'm looking at our time. We'll put some more testimony up next week. And if you have suggestions for folks you would like to hear from, it's not gonna be a whole litany, it's not gonna be 3 hours, but we can certainly put some testimony up to try to answer questions. All questions can't always be answered, but we'll do what we can to do that. And then we'll come back to the bill. And as I said, our goal is to keep moving on it. So if you have specific people or information you want, we'll try to get that for you. The best I can say, the people who are out there who can respond to your questions, you'll get them. I agree with both you and Senator Hardy about the ability to go cold turkey. Doesn't always work.
I think it
Sometimes
depends on what your
horrific.
addiction is and what you're using.
It depends on a lot, Senator. You're absolutely
And so
right.
that's why I said we should hear from a medical doctor.
I
on
understand.
addiction.
I know, I understand that. And if you've seen it, you know how horrific it is. So you've seen it, and I've seen it, and others have, so anyway.
I'm too dainty in my hand raising. I need to be a
You're
little more
there,
out
you're
there.
there.
I can have this conversation with my colleague offline, but I do wanna I wanna understand a little bit better what he means by total solution. Because I think that's a really interesting phrase and also it's a phrase that I don't hear very often because we rarely ask our government, our municipalities, our medical society to create a total solution for anything. So I just want to, I just want to say that I appreciate that. I'd like to learn more about what that means. Yeah, just put
So,
that out there.
shall I? It's very brief.
Yeah, then we're gonna scoop.
I get
Okay.
it. So to me, part of the problem with government is we keep solving individual problems, aspects of problems as opposed to looking at the whole issue and trying to solve the problem from beginning to end. From how did the individual migrate into such a, to be an addict through the to the point of returning to be self-sufficient citizen. Okay, that's what I mean by the total problem, which requires a full range solution, all the aspects of it, all the way through. No one's come in here from A to Z to say, okay, look, this is the full trajectory of the problem. This is what's working. This is what we're trying. This is what has not worked. It takes all the way through. The second bit is you asked about the statewide problem. I think we know enough. There's enough subject matter experts out there, and many of them have already come through this award to talk to us about the scope of the problem, how large the problem is, whether it's how big the problem is in your county or my county, et cetera. So I think we have enough data to understand how many folks are adversely affected, meaning, personally as the addiction, okay? And if this solution is a viable part of the solution, which it may very well be, okay, listening, okay, I think we can make assumptions on, well, okay, if it works in these pilot sites, where does it go next? Like, what's the scope of what we need to do as part of the larger solution? That's what I'm getting at.
We get it. And also what I'm gonna do is gonna let Michelle have the last word, and then we're gonna turn to Katie. But I appreciate your question, and it's a huge conversation.
I just wanted to note for you that in the research report that you're gonna have, and looking at the pilot programs, is that there's language in there that they're also to be looking at things statewide. And then with a focus on those communities where the OPCs are established. And so I think you're gonna be getting back some information about, like, so they say, where are all the EMS calls related to overdoses? Where are you seeing the overdoses? And then what is the impact on the communities there? And so you might want to review that. You might want to tweak or suggest some tweaks to that language around, because I think the goal is that you're going to be getting some statewide data, not just on those communities where the OPCs are located. And so you could see maybe where the hot spots are. So if it was successful and the legislature did want to expand the program into another community, I think you could use some of the data that's coming back to you from the DOH study.
Okay, nope, that's it. We're done. And
So I
if you
agree
have,
with you.
if you need to have a conversation
I think we
outside,
already know.
Senator. Thank you. If we need to have conversations outside, we can do that. You can ask Michelle for clarity on what's in the bill. But we're gonna move on and we'll finish our testimony next week on this bill, and then we'll move ahead to markup. I hear the questions. Some of them are relevant, some of them are in the bill, and some of them are not. So just go ahead. Before you leave, Senator, we're going to move to Katie McClinn, and we're gonna go on to H543 briefly.
Can I be back in 2 minutes?
No, yes, right, depends on, no.
What?
Oh, come on, she's a grown up.
That's all right.
I think let's do this one thing.
Well,
and then-
Are you getting it in Dave's office?
No, it's all right. It's all right. I was gonna go upstairs. I also need other.
Oh, that wasn't 2 minutes, I could kill that.
Three and a half.
We're gonna try and take a break.
Okay,
We'll look at the bill.
thank you.
So Katie, thank you for doing.
You're welcome.
Thanks, Michelle.
Thanks.
Thanks, Michelle.
Good morning, happy Friday.
Happy Friday.
Let's see how happy everybody is in this room. It's a good discussion.
It is, yes. This is what we should be doing, yeah. We're a community here.
Yeah.
We all need, I'd like to see us all agree on everything.
Okay,
I think we have the knowledge to do that, the expertise.
I agree.
Hey,
Well, this morning I'm here to talk about H 543, which is your social work licensure compact. And then I guess I'll also be back later in the morning to go through the peer support and recovery specialist bills. So I can pull up, we've been looking at the section by section summary kind of evidence bill. We've gone through it a couple of times at this point.
Are there any amendments that have been placed into the bill and,
Not on the Senate side, no.
and is there anything that we can affect?
Yes. So if you remember the first, oh, I don't have it in the section by section summary. That's not helpful. Let me pull up the actual bill. So if you remember the conversation about compact, we can't make significant changes to the compacts themselves, but things that can be changed. For example, is language at the very end, OPR on the House side asked for an amendment. And the amendment wasn't to the compact language itself, but it was an additional section that was added to the bill that authorized the department, not the department, the office, to do criminal background history checks. And they have a list of entities that they can currently do that check for, and social workers were added to that list so that under the compact, they need to have that authority. And so this would give them that authority.
And we heard Lauren Lehman speak to this.
You did.
Yeah.
And then the other change was the effective date. It had gone back and forth a few times on the House side, but it is on passage, the bill that you have in front of you, and that's what OPR had requested.
And it does allow for us to be on the ground floor with the compact.
It does.
Maybe, I don't know what the other states are doing, because there are a lot of states.
There's a lot of stuff going on right now,
Yeah.
right? Okay, so any questions of Katie? Good, okay, I would entertain. a motion.
I will move, that we recommend for, passage, pass H 543 as passed by the House.
Is it as passed, and is it effective date is as passed by the House?
Yes.
Okay,
Passage.
all right.
Where's my paper? Where's my paper? Here it is, yay, thank you, Senator. This is exciting, by the way. Even though I know the compact bills seem a little humdrum at this point, it's kind of exciting. It's good to get things checked off our list.
It
That's where I'm
sure
at right
is.
now. Like, okay, let's get this going, so we don't have to. So we're still in the original, correct, it was 2.1.
Nope, it's as passed House.
Nice to have a concurrence.
One bill that doesn't have to go to conference.
After, okay, you're gonna go to a vote. Vice Chair Weeks, Felix?
Yes.
Thank you. Senator Keeling, yes. Senator Hardy? Yes. Senator Williams?
Yes,
And Chair Lyons?
Yes,
Great, 5-0-0 on the vote.
okay, who wants to report this?
Did you say you? Did you? Oh,
did the last one.
okay.
Yeah,
Yeah,
Who's doing the other, the
so it's on notice for Tuesday.
occupational therapist?
yeah, so this will be on notice for Wednesday.
So Senator Williams, you wanna do it?
I'd love to.
Fantastic.
Update that section by section.
Practice makes perfect.
Practice is made perfect.
You're getting better and better with your bill reports,
Every day,
yeah.
So let's go, unless they say don't make it short, then you
Yes.
can't give all the information, and that's not fair.
The call
So,
was-
I'll see you later. Thank
Bye,
you.
I'll be back
Thanks.
after.
So we're gonna go offline and take a